So let me introduce Loveda to everyone. So she is a PMHNP. She's one of our top students in our academy. Very helpful. I've learned a lot from her. And so she went to the University of Texas Pan American for undergrad, then practiced as an RN for over 10 years. And then after that, did her PMHNP at University of Texas Health Science Center, and then now she works as a PMHP outpatient in San Antonio. So
Nice to meet everybody.
yeah, of course, and thank you again for being here. What I really wanted to ask you was, I just kind of wanted you to like walk us through your journey, like walk us through like undergrad and then nursing school, like how did you end up coming on this path and then where you're at now?
Okay, so I guess I would say I wanted to be a nurse back since I was a kid. I remember my grandma had had like some kind of injury, and a home health nurse came, and I thought, oh, that's cool, that's interesting. And I really enjoy science. So I went down the nursing path. And then when I was doing my clinicals, it was down to mental health and NICU. Those were my top choices. But I ended up getting a job in NICU, so that kind of guided me that way. So I did that for about a year and a half, and then I did pediatrics, home health, and geriatrics. And then I worked as an RN with individuals with intellectual disabilities, and I saw the need for more nurse practitioners, especially in psychiatry. So when I had extra time and I was working part-time during the pandemic, I enrolled in a hybrid program.
Got you. Okay. So really, you went through school, then you started seeing the need, right, as you were practicing, and then that inspired you to, get your nurse practitioner degree as well.
Yes.
Yeah. What exactly were you seeing during your when you were in your clinicals, and plus when you were practicing as an RN?
Well, during my clinicals, I enjoyed the mental health clinical rotation. It's just a shame that it was one semester and the
Yeah.
hours were kind of limited, so you just kind of get a taste for it. But when I was working with individuals with the intellectual disabilities, um, it was very difficult for them to initiate services with psychiatry and to have the support that they needed and the availability for appointments.
Yeah.
And also, I saw the need for, more thorough education for patients regarding medications and diet lifestyle changes due to limited appointment time.
Got you. Got you. And then so you really saw this need happen, right? And then what did that change in you? Like, so you want to go get your degree, right? Like, were you hoping to work back in that area? Were you hoping to go somewhere else?
Well, I do really enjoy working with patients with IDD, but I also enjoy treating serious mental illness, psychosis, particularly.
Got you. Got you. Okay. So really, like, I think you have a wide variety of interests too.
Hmm.
Yeah.
Definitely.
And then something else I wanted to touch on was that you said that as a kid, you always had that interest in science, right? And that's what led you down the nursing background.
Yes.
Yeah. So when you were pursuing that, did you have any like did you only want to do it from a nursing side, or were you like wondering from other perspectives as well? You could like research, medicine, PA.
Yeah, I had thought about PA, but then I ended up doing the nursing route, and then after that, I realized, oh, hey, there's a nurse practitioner route. So then I went the nurse practitioner route.
Got you, got you. Okay. So really for you, like that was just was there anything that led you towards like one route compared to the others, like especially at the beginning?
Yeah, so in nursing, you get to start your practice a lot sooner, and you have a wide variety of specialties. So you
Yeah.
can kind of narrow it down to if you want to, work with a specialist, if you want to do home health or outpatient or surgery or so I like the flexibility of the different options.
Uh-huh. Gotcha. So really it was that when you had that flexibility, you could have gone in doing whatever, and then that's when you saw the psych need, you saw the NICU need, and then kind of went in from there.
Yeah. I like to think that your specialty finds you, honestly. I just
Yes.
circled back to it.
Yeah. Yeah, that reminds me, because I remember one time I was in a live and a med student came on and he asked me, uh, convinced me to go into psychiatry. And I remember telling him, like, bro, if I need to convince you to go in, then it's not for you.
Agreed.
Yeah. So I'm curious, like now that you're practicing, how has that shaped you just as a person? Like, getting exposure to psych, seeing psychiatry, like what is real world psychiatry like compared to like what you thought it was?
Definitely a lot of behind the scenes work and time and effort that goes into it that you don't see. I feel like a
Yeah.
lot of times patients show up for the visit and sometimes they have the idea that it's very stress free and relaxing on our end, which it's not. You have limited time to get the information you need to document, to diagnose, to send the meds, and at the same time, you
Uh-huh.
know, cultivate and continue to develop that therapeutic relationship. So I find, you know, having communication skills, good communication skills is super important, which I did not realize before.
Yeah. Yeah. It is very huge. I remember a story that I had was I was in my first year of residency and I was interviewing a patient. And when I'm interviewing this patient, the patient starts like it was an emotional moment, and so the patient starts crying, and immediately I'm like, oh my god, like let me back up here. But the interview went fine, and then afterwards the attending talks to me, and she's like, wow, I've never seen a patient cry like that. I was like, oh, I didn't mean to, and what she told me was that no, I think it's actually good because you were able to get the patient to reflect emotion, to reflect some affect. And I think like, that's going to help them bond with you more than just like a flat, stone faced interview.
Mhm.
And so that's what that reminded me of when you were saying that.
Yeah, you become more aware too of how you communicate with others, not just how you perceive their communication.
Hmm.
So during the consults and even during the initial intake, so it's our job and responsibility to make the patient feel comfortable so that they could open up about really sensitive things maybe they've never discussed with anybody or traumatic events. So
Yeah.
we kind of have to set that tone. So you have to be aware of your body language, what you say, how you say it.
Yeah. So how do you go about making patients comfortable when they come to see you?
I've learned to do my own thing as far as using my personality. So I don't view it as, hey, this is a patient, this is the relationship, this is going to be the interaction. I view it as I try and treat them as a friend, make them feel comfortable, and kind of explain the process. So usually there's like a nice greeting. I ask them about something, or I compliment something they're wearing, ask them how their day's going. And then I ask them if it's their first time visiting psychiatry and what their previous experience was like. And if they explain it's their first time, I will tell them, well, we have this set time frame. It's an hour. Usually the first visit's longer. I kind of explain the process. I'm going to ask you questions, get your history, and then we'll talk different options and about the different forms you filled out. And along the way, we can talk about things and you can ask me questions.
Got you. Okay, so it's like very you kind of integrate your own personality into it. You're more open with them. Do you find that you tend to be more authoritative, talkative, or you usually are more like laid back and kind of let them talk? Like, how is your style there?
I think you have to find the right balance. So I feel like the first few minutes are really important to get them to feel comfortable and to be
Yeah,
a little bit more informal and have them open up. And then you can guide and direct it as you go, obviously, because you still have a lot of information to get within that limited time.
yeah,
But sometimes they do need some extra time and they have a lot of venting to do.
yes,
That's okay. I think the important thing is they need to feel like there's a relationship and they're feeling heard.
yeah. And I think you offer a very unique perspective too, because I'm sure a lot of our audience is either RNs or nurse practitioners. right? Either aspiring or there are other kind of providers. So I think you offer that unique perspective that I cannot. I'm glad that you're, sharing your journey with us and just your experience. Yeah,
Well, if you
yeah.
can help others, why not?
So if you had aspiring people coming up to you and they were asking, "Hey, how do I get started on this journey? What do I need to know? What kind of advice would you give me? Like, what would you say to them?"
Regarding nursing or psych NP or like masters or both?
Yeah, let's go with nursing, and then we can go into psych and P.
Nursing, like I said, I think it's a great option as far as like you have the different varieties and then you could decide what you're going to specialize in and the flexibility. You have different kind of hours, different kind of jobs. So some do like the 312s, others do the 8-hour shifts. So you find what works for you and your lifestyle and your family as well.
Yeah, got you. So you're very flexible with the schedule.
Yeah.
Yeah, and then now let's say someone has passed their nursing boards and now they're looking at kind of becoming the practitioner route. What advice or what would you tell them?
Well, I believe now most programs require at least 1 year experience, which is good because I think there was a time when they didn't. So usually they require at least the 1 year experience in whatever specialty route you're going to go into.
Yeah,
So what a lot of people do is they just go the F&P general route, and then from there they branch off into whatever specialty they want, whether it's acute or women's health. Just because if they end up not really liking the specialty they have in mind, they still have the general license to where they can go back and specialize somewhere else, kind of like with the general RN license that you can diversify.
got you. Okay, so you have a lot of options then.
Yes, for sure.
Yeah. And so, something as I've been becoming involved in this world, I'm realizing that there's a lot of problems with the education system. That you've told me that. I know some of our other students have said this too. So, like, what's your take on it? How do you feel like the NP education system is?
So when you go to school, even for nursing, but I feel like nursing, they're a little bit more accurate when it comes to the clinicals and a little bit more specific. So you do get a little bit more training, but most of it is on the job. So whenever you get your job, that's when you're trained and you learn.
Yes.
Um, as far as master's level, they give you the theories and the basic foundations to prepare you for the exams. And when it comes to clinical, it depends on your preceptor, how proactive they are about teaching you.
Yeah.
Um, and as far as your location, it's really difficult to find a preceptor in the first place. So you can't have in mind, oh, I want to, go have clinicals at the VA because it all depends on availability and you have to do it months in advance. So it's really difficult to find a last minute unless you actually move close to the campus. So then there's a lot more availability since they're closer to campus, they have more contracts. So that's a whole process of itself too. I remember for my first semester, I had such a hard time finding a local place. I had to actually go live in Houston for like a month and take a month off of work to just focus on the clinicals.
Oh, wow. Okay. So they just kind of expect you to fend for yourself.
Exactly. And so let's say you want to have clinicals at a location and, you get them on board, you have to communicate with the individual in charge of contracts at the university, and then they communicate with them, and then you're mediating because it's all done through like contract, and then you also have an insurance when you're doing your clinicals.
Yeah. Okay. And then, as you were saying, the quality can vary significantly depending on the preceptor.
Yes.
Okay. And is that for NP school in general? Is that for specifically for like PMHNP?
Um, I can only attest to PMHNP.
Okay. Gotcha.
But I assume it's the same for all NPs, from what I've heard.
And then what about the course curriculum? Like how is that?
Uh, well, the course curriculum is pretty basic, I'd say, when it comes to the science. Like, we don't have the same thorough science education that, medical students have.
Yeah.
It's very basic and to the point.
Okay.
So it's always nice to talk to doctors and other specialists who have more of the specifics as to that, and to learn more about the neurotransmitters and the different processes and the more complicated things.
I see. So you don't learn about neurotransmitters then? They don't go into that?
You do, but it's basic.
Yeah. Okay. And what do they expect? Do they expect that it's not important or that you don't need to know it?
I really don't know their theory behind it.
Yeah.
I just know it would be like, let's say we'd have modules that would be up. It'd be PowerPoints. You have to study PowerPoints. They'll give you assignments of different books to read, whether it's patho or whatever books are on the syllabus for that specific course.
Yeah.
And then, so it's just memorizing the facts and the information and then taking the exams.
Gotcha. Okay. And then you do that, right? And then you get that done, you learn what you need to, and then you're just ready for practice. Is that how it works? Like, what's the process once you
So
graduate?
the first few months, it's the foundational stuff, what overlaps with FNPs as well. So all of the different nursing master's level, you have this core curriculum that you do first. So that's the first few months, which is the classes, the exams. Part of the overlap, you have a assessment course with a lab clinical, and you have a patho one and a pharmacology. So you do that the first few months.
Mhm.
And then the last 3 semesters, that's when you have your clinicals.
Okay.
So your clinicals, you do it during the time frame when you're enrolled in school, because that's when the insurance covers you. So you can't do it in between. You might be able to during spring break, I believe, as long as it's okayed by the director and your preceptor.
Yeah. Got you. Okay. So that's kind of what that's what it's like, right? Then you do a couple months of clinicals and then you graduate.
Yes.
And then so like what happens after graduation?
After you graduate, you sign up for the boards exam.
Uh-huh.
You get it verified with the school. They send a document over to the state boards that you're able to take the exam. You take the exam and then you start applying for jobs. So the first one's really difficult because you don't have the experience.
Yeah. And yeah, because I can imagine, right? And when you're looking for jobs, what do they look for? How do you know what to look for? Like, how do you know if a job's going to be good or not? And what kind of guidance do they tell you?
All I remember our previous director guiding us for is saying when it comes to pay, not to accept anything below a certain annual amount of salary. Or if you do contract, not to do anything that's not like 70-30 minimum.
Yeah.
And again, that's Houston, so it's a different pay rate. So you don't always get that.
Yeah. So in your case, it looks like you were already knowing that you wanted to stay in Texas.
Yeah.
Yeah, got you. And so when you were applying to jobs, like what was that journey like for you?
It was stressful.
Yeah.
So you'd apply for a job and then you get a call and then you interview. And I feel like a lot of the interview too was the communication and the body language. And so you know that it was a good interview, you had a good impression if you are scheduled for a second interview.
Mm-hmm.
And then once you have the second interview, then you talk business and the paperwork and salary and contract.
Yeah, gotcha.
It took me a few months to find my first job. So the good thing is when I graduated and I took my boards and all that, I still kept my old job. So I was still working while I was applying and still studying and working on my cheat sheet to prepare for when I was in practice.
Yeah. Yes. Yeah. Yeah. Your handy cheat sheet's been very helpful for sharing that. Um, so yeah. So then you applied for jobs, right? And then how'd you kind of did you just apply for the one job? Did you apply for different ones?
I applied for a lot of jobs.
Okay.
And it took me, how long did it take? Maybe about, I passed my boards end of January and then I got my job beginning of May.
Yeah. So it
So
took a
yeah, like
couple
3 months.
Yeah. And what was your experience with your first job, like once you got signed up?
So before I signed up with my first job, there was another job that I was signed up for as well, and I had gone along with the second interview. It's just the timing of this one, and I wouldn't have to move. But what made me hesitant about the other job, it was supposed to be in San Antonio, surprisingly, because I'm not from San Antonio.
Yeah.
Um, but I didn't like the fact that they didn't say how many patients I was going to see in a day when I asked. So I'm like, that's not a good sign. And it
Mm,
was all going to be kids with ADHD.
yeah.
So my experience would not be as diverse. And I would be under a supervising general doctor, not a psychiatrist. So I wouldn't really learn as much about my specialty. And I'd have to move. And then the second option, which is the one I decided to go for, that one was a local job, so I wouldn't have to move. Um, and they did claim I would see less patients, but I ended up seeing way more than what they claimed, obviously.
Yeah. So they kind of misled you there.
Yes, for sure.
So,
And
and
I mean, I had heard things about the place, but you just think, okay, they're willing to provide me with this experience. I'm going to learn. So
yeah,
take what you can.
yeah. Got you. So you stuck with it. How was your supervision or collaboration there?
So he would make himself available through text, but he was on vacation quite frequently,
I see.
like every month for like 2 weeks at a time.
Okay.
But there was a PA that was there, and she had been there for a few years. So she was a really good resource to have. The problem was we would be seeing a lot of patients, both of us. So I'd see a lot, but she would see a lot more. She would see like unheard of amounts in a day, like 50, and I'd see like 30 in a day.
That's
But
a
she
lot.
was helpful in that if she was finished early and she'd see that I still had patients to see, she'd help me out. But obviously, it was difficult if I had a question or a concern and she was seeing a patient and I was with the patient.
Yeah. Yeah. That's still a lot of patients though to see, 30 or 50 a day.
Yes, it is, especially as a new grad.
Yeah.
So I went through the fire.
Yeah, no, exactly. And how did you feel? Did you feel confident during it? Did you feel overwhelmed?
No, you feel overwhelmed
Yeah.
for sure. But you get by. You take it one day at a time. The good thing about it is when you're busy, it goes by really quick.
Yeah.
And I did learn a lot because we had a Spravato clinic that we'd each help out with one day a week. And while we were overseeing the Spravato, we'd also do the REMS documentation for it. And we'd still be seeing patients. So I also got to learn a lot about the newer meds, the long-acting injectables, a lot of serious mental illness, all ages from like 4 to geriatric. Um, there just wasn't any work-life balance, and I didn't even have lunch, honestly.
Yeah. Like it was just straight working.
Yeah.
And so when you had that many patients, how did you do your learning, keep up with it?
Um, Learning as you go, learning off the clock for sure. That still doesn't end. Even when you're experienced, there's always new meds and new things you're learning.
Hmm.
Um, Talking to the reps. So when the reps would come, I actually had a lunch because I was forced to talk to the reps.
Yeah. Okay.
So it was something I looked forward to and they looked forward to.
Yeah.
And also the dinners that they'd invite you to. So yeah, talking to. There was also a group me chat that I had with my previous classmates, but it kind of really died down afterward. So we had
Yeah.
it active while we were in clinicals, and we would help each other out with exams, and we'd each do like sections to like prepare for exams, like make our own study material. But then a few months after we graduated, it just died. So that was a good resource to have too.
Right. Well, while it lasted, it was good.
Yeah.
Yeah. And yeah, so I think, I think your experience is very valuable because you've been through this process. So if there's a new PMNHP who's listening to this, right, they might be about to start their first job, or, they're dreading having to see the 30 or 50 patients like you mentioned. Like, what advice would you give to a person in that position?
To advocate for yourself and advocate for your patients and their safety, to have good boundaries and good self-care. So you can only do it short term, and then eventually it's going to catch up with you and you're going to burn out.
Yeah.
And you can't take care of others if you don't take care of yourself.
Yeah. I think that's very true. How do you take care of yourself?
Um, I would say I can get overstimulated at times, so I definitely do give myself extra downtime than the average person. I'll go for walks on trails, I'll go to the gym. I eat healthy by choice, but also because I'm pretty particular about things I eat. So I can't eat just anything, so I lean more towards like Mediterranean and fruits and vegetables just because that's what my body likes.
So it's so important. It makes such a huge difference.
Yes. And sleep too.
Yeah. I remember, when I was in my early 20s, I remember, I was in college and I slept maybe 3 or 4 hours that one night. I think we had a gathering or something the night before. The next day I had to go to the bank, and I'm going to the bank and I remember feeling really good. And so I remember talking to the banker about it, like, yeah, we slept 3 or 4 hours and I feel great. And he goes, okay, just wait, just wait. Because I was like 21 at the time. Now I'm like, wow, I can't believe that we were able to survive on that. So,
Yeah,
wholehearted.
it's different when you're younger. When you're younger, you can do stuff like that. And as you get older, you just can't. I remember my first job when I did NICU, it was night shift, but I was 23. So did that okay for a few years, a year and a half. But the advice that the nurses gave me is whenever you work night shift, the days you're off, you sleep your regular routine. You stay awake during the day, so when you get off your shift, you pull a long day of 24 hours, no sleep, and then you
Hmm.
sleep at night. And
Yeah,
then your days off, you sleep regularly at night. That way you're not stuck to just being up during the night shift. Because then you can't switch back to day shift. Your body gets used to it.
yeah, that's very smart. You just have to like kind of power through that.
Yep. Helpful
Yeah,
advice from experienced people.
yeah, exactly. And so I think that's the advice that you're able to share with people who are like one step behind you too. So then, what led you from transferring from your first job to your second job?
Less patients per day, so more time with the patients, and I'd be able to practice more of the therapeutic communication. Because
Uh-huh.
with my first job, there were a lot of issues, obviously.
Yeah,
So I had discussed the issues with the doctor, who was the owner of the business, and I had discussed them with the manager, and they'd make promises, but things wouldn't change, you know? So actions over words and promises.
yeah,
Um, but yeah, the scheduling, they would schedule patients every 15 minutes and they would overlap patients. So I would feel horrible for the patients. They'd be waiting 4 or 5 hours in the lobby to be seen. And then when I see them, the appointment is very limited because I see so many people. So it's like a 5, 10 minute visit, quick check in with meds.
yeah,
And my patients told me themselves. So anytime they'd be upset, I'd apologize and I tell them, hey, go talk to the manager next door. She's the one overseeing the schedule. And she'd get upset about it, but I don't
yeah.
really care.
How
But my patients told me that it reflected on myself as well if I was willing to do that.
yeah.
So I took my leave. So at this other job, I'm able to do initials. I have a full hour to do that. And for follow ups, I have 20 minutes.
Uh-huh.
Recently, I advocated more for myself and I got admin time daily, 20 minutes, but it's something. So I got admin time, and I also mentioned that for the more complex patients with a lot more things going on, I need longer appointments. So she allowed me flexibility to have 30 and 40-minute follow-ups if needed.
Wow. Okay. So it sounds like at least here they're willing to work with you.
Yes.
Yeah, and I think that's key that people should listen to is that, if the practice isn't willing to work with you, it tells you how much they value you.
Yeah, I just feel like it's a lot of therapy skills and boundaries that apply in day-to-day life with any relationship, and it transfers over to everything else.
Yeah.
So people will treat you however you allow them to treat you, any relationship.
Right. No, that's so important with patients, both with anyone else. I was gonna ask actually, so regarding boundaries, have you ever had that crossed either from like, patient if you're seeing so much volume, I'm sure like there's been situations like that.
As
Like
far
the
as,
patients cross boundaries or like you mentioned the clinic was crossing them.
yeah, so the first job with the more difficult patients that were in and out of hospitals and, bipolar, substance use, borderline. Um, we were really big on doing drug screens because we had to, because of the coexisting substance use. I have had rude patients. So I remember I had this really rude patient that she was not compliant with her drug screen. We hadn't seen her in months, and she wanted clonazepam in her previous drug screen. I think it was like over a year ago, and it showed illicit substances.
Uh-huh.
So I asked her to be professional and to lower her voice, to stop cursing. She didn't listen. I asked her again. I told her, okay, you continue this, I'm going to hang up on you. So I hung
Yeah.
up on her because she didn't stop, obviously. And I
Yeah.
told the manager what happened. And I explained, hey, look, this patient's going to call and probably be upset. This is what happened. So she flipped the story around and she said I was the one saying what she was saying. I'm like, okay, all right. And she saw somebody else and she came and did her drug screen anyway. So all that drama for nothing.
Or nothing. Yeah.
Exactly.
But no, it's good that you were able to protect yourself against that too, because like that could have escalated.
Yeah.
You knew not to react either.
Yeah. And you get the vibes and when somebody uses. I mean, there's always the cases that surprise you when you do a drug screen and stuff comes up that shouldn't.
Yeah.
But it is what it is. You work with them. So when it comes to stimulants, that's where I'm more careful with the drug screens, just because you never know. And a lot of times with all these pop-up shops everywhere with the cannabis and the THC,
Hmm.
patients think it's legal because it's in a shop. And even with the vaping, they don't even know what's in there or the percentage really.
Right.
So
Exactly.
they're surprised themselves when they see it in the drug screen sometimes.
Yeah. Yeah. I remember it reminds me of a case I had. So I was in like I was working at community mental health at the time, and there's a gentleman who I was treating for ADHD, and he had a remote history of alcohol use disorder. Swore that he was clean. In UDS, you can't really test as well for alcohol, but it was a remote history. So unless you like look for specific metabolites, and so I trusted him. We started stimulant treatment, and then fast forward a couple months later, so this was telehealth, and his the nurse gives me a call, and so I'm like, hey, like what's going on? It looks like we're about to see the patient, and then the nurse is like, yeah, he just came in and his breath smells like alcohol, and I was uh, like, so in that case, I had given him the benefit of the doubt. I had trusted him, and he had said that he was going to be clean the whole time, and he was doing well. And so, I still remember that because I'm like, oh man, now I have to. We had an agreement, and you reneged on this agreement.
Hmm.
We have to.
Yeah, and I always mention to them it's protocol because it's a liability for us and it's liability for them. I mean, it's a safety thing.
Yeah.
Any medication and mixing alcohol and substances is not good, much less controlled meds.
Hmm. Right. Something else I was also curious about. So I know that you have a strong interest in ASD.
Yes.
Is that accurate?
Yes, it is accurate.
Okay. So yeah, tell us more about that. Like, how did that develop? Like, what do people should know about it that most people don't?
Um, so it's more personal, honestly. So I had a nephew that was diagnosed with ASD when he was young. Um, and my sister saw similarities with myself. So during the pandemic, I had extra time and she kept telling me, so I got tired of her telling me that she thought I was autistic. So I did online quizzes and they screened positive. So I thought,
Yeah.
okay, I mention it to my psychiatrist because during the pandemic, I started seeing a psychiatrist. I had always had insomnia forever since I was a kid, which was a pain. But
Yeah.
back then it was different time. There wasn't any resources, or if there were, they were pretty limited. So my mom would take me to the doctor and she'd tell them, hey, she can't sleep. She has issues with sleep. And they didn't recommend any therapy or anything. It was the 90s. So I always thought, okay, I just have to live with it. And in the pandemic, it got pretty bad because I didn't have a routine and a schedule, so it affected my sleep. So I went and I got on mirtazapine, and it helped with sleep. It helped with my anxiety. So I did much better, but then I told the psychiatrist, hey, I want to roll out ASD. How do we go about it? He said, okay, that would be through a psychologist. So I booked an appointment with a psychologist. And when I mentioned to him what I wanted to roll out, he disagreed with me because he said that I should have been diagnosed since I was a kid because it's pretty obvious.
Hmm.
All right. And I never struggled in school. I always got really good grades. So I did the intake. It was a lot of questionnaires for me to fill out, interview. I gave some to my ex-husband at the time, and he filled out questionnaires too. And
Hmm.
then at the end of it, I screened positive for ASD, mild.
Yeah.
So I did all that process to prove to my sister I didn't have it, but I did have it. But it
Yeah.
was good. I mean, you learn about yourself and you realize, like, honestly, you're different since you're a kid, but you just don't know what it is and you can't pinpoint it. And
Yeah.
then when you have the diagnosis, you're like, okay, none of this was in my head. It all makes sense now. It's like, no wonder I would practice social interactions I was going to have with others. Like, I always thought that was a normal thing to do, but apparently it's
Yeah.
not.
Yeah. So okay. So walk us through like what sort of things did you start observing about yourself like once you had the diagnosis? Looking
Once
back.
I had the diagnosis,
Yeah.
um, I realized that when I would be irritable with people, it wasn't because that was my personality. It was more because I wasn't sleeping well or I was overstimulated by things. So by saying no to social activities and saying no to people and situations if I didn't feel up for it and taking care of myself, then I could be the best version of myself when I did go out and spend time with people.
Yeah. Got you. So it's the irritability, right? You also mentioned stuff as a kid that you felt different. Like what sort of things had you noticed?
Um, I would probably say my earliest memory would be like when I was in pre-K, I would come home and do my homework.
Okay.
I always thought that was normal, but then once
Yeah.
my nephews were born and I saw what a struggle it was for them, I'm like, I guess that wasn't normal.
Hmm.
Also with school, like I would wake myself up and get myself dressed, like way too responsible for a toddler.
Okay. So you were very, I guess, unkid-like, like
Yeah.
like an
More
adult.
mature for my age
Sure.
in
Yeah.
some things, but in some things, like In some things, I would say that I didn't quite make the connections as to what I did was wrong in certain scenarios. So I remember there was this other time when I was playing with my sister and my nephew. I think I was maybe like 6 or 7. Um, and then I thought it would be cool to distract like the adults that were in the living room by like turning on the blender and sneaking in. And then I ended up getting in trouble for turning on the blender. I'm like, what did I do wrong?
Yeah, that's funny. Okay, so you had some interesting ideas about pranks and
Yeah, for sure.
yeah. Gotcha. What about social interactions? How are those?
Um, I guess I didn't really understand small talk. It took me a while to get that down.
Yeah. Okay.
Just because, like, in my mind, and a lot of people with ASD, we have commonalities, but it's a whole spectrum. So, like, how it presents from person to person.
Right.
Um, but generally, we don't really like small talk, but I've learned to like it because it makes other people comfortable, especially my patients. And I've found that I do actually enjoy it because there's a purpose to small talk. It's not just to waste your time, like I
Yeah.
thought before.
Yeah. So I think that's the key therapy principle right there. You reframed it. And because you went from reframing small talk as just a pointless thing to, okay, now there's a goal associated with it. It makes
Yeah.
sense
I
to,
think because before, and a lot of people on the spectrum too, from what they've told me, is when you have a conversation, you want to talk about things you learned and things you're interested in. It's productive and it's engaging, and not everybody feels that way.
yeah,
And that's okay.
yeah. That reminds me, I can't remember who I was talking to, but we were talking about like about guys hanging out versus girls, and how when girls hang out, it's centered around dialogue, communication. It's
Hmm.
right the sleepover party, or just hey, let's get a coffee and catch up, or let's hop on the phone for 2 hours. I would never hop on the phone and talk for 2 hours with any of my guy friends.
Yeah, different standards, right?
Right, because for us, it's centered around activities, our interaction. Like, hey, let's go watch the game. Hey, let's go play a game together. Hey, let's go watch this thing. Let's go grab a drink. Like, it's always centered around some kind of let's go fishing. There's always an activity that brings guys together, or
Yeah, I would say that part of that is societal too, expectations. That, I mean, even in theory, when it comes to parenting, like the mom is the one that deals with the medical and the emotional stuff and the conversations, and the guy just goes to work and pays the bills.
right. I think it's both nature and nurture, because like inherently, there's parts of us that want to do that.
Hmm.
So it's all a spectrum.
Yeah, that's a really good documentary about that, actually. I just need to look it up and find the name. So it's about this guy that during the pandemic, he really struggled with his mental health and he died by suicide. And so his friends created this documentary to talk about that. How, you go to a bar and you observe men. They're all just sitting next to each other, but they're not talking about how they're feeling or what's going on.
Right. Yeah. And not dancing either.
True.
Yeah. So, um, something else I was also wondering is that we talk about bias, right? And so, there's definitely bias that people experience both as, uh, people on the neurodivergent spectrum, right? You can experience a bias there. I mean, bias as a NP as well. So I'm just curious if you've experienced anything like that.
Bias, as in when I tell people I'm neurodivergent?
Either you tell people you are, yeah, or people perceive you as being different.
Yeah. So I would say generally when you tell people you're neurodivergent, they don't know what to say. So they're just quiet. awkward silence. Or you get the other extreme where people apologize and they say they're sorry.
Yeah.
Which either is not really helpful, but then you do get a few people that they're accepting of it, which is great.
Yeah. Has it impacted ability to make friends now?
As an adult,
Yeah.
I wouldn't say so because I've always preferred to have a few close friends than a ton of friends that I'm not really close to. And I've still maintained some friendships from back when I was like 19 or 20. Obviously, we live in different places and stuff, but we still keep in touch. It's
Right.
not one of those relationships where we say, hey, we're not talking, so we're just not on good terms. We're not friends. Like, we understand our need for space, so we can go months without talking to each other, and then we catch up, we meet up, or we talk, and it's like we just never parted ways, and that's fine.
Yeah.
I have made new friends, different places or online or in person. Uh, but yeah, I just find that if you accept yourself and your differences, you're okay. Like, not everyone's going to be best friends with you, and that's okay. It's just like with the patients, too. Not everyone's going to like you, and that's fine.
Exactly. Yeah.
Whatever works for them. But I would say it definitely helps with patience because I focus on the strengths, which I'm very big on details. So I know what to look for. Let's say they're people that mask really well or they get really good grades.
Mm-hmm.
I know what details to look for. I know what to ask. And I self-disclose as needed. And patients like that. They
Got
like that they have a provider who understands them and isn't just labeling them, putting them in a box, because nobody really belongs in a box.
Yeah, which is really key. It's a good rapport strategy too when you're doing a patient interview.
Yeah. But then they asked me if I know any therapists who are neurodivergent, and I don't really.
Uh-huh. Well, it sounds like we gotta build up that Rolodex then,
Yep.
a list or something. Yeah, gotcha. And then what about as an NP? Have you experienced any bias, any pushback, anything like that?
Um, I would say a lot of people are hesitant to share it because of how they're going to be judged or perceived by others. Um, so I wouldn't say there's a right or wrong answer. It depends on where you're at and how comfortable you feel. Like for some people, they say, oh, I'm on the spectrum or I'm autistic, and others tell you not to say that. But if you want to, then go ahead. And I find it's actually helpful if you do it as far as your work environment because they'll better understand you and work with you because it doesn't just affect your communication, like it affects everything.
Got you. Yeah. And so you find that if you're more open about it, then it makes things easier, especially than if you're not.
Yeah. And then you don't really have to explain yourself when you're not up for doing certain things.
Yeah.
But I
Yeah.
have had patients recently ask me about my thoughts with RFK and whether or not they should get diagnosed.
Uh-huh.
So I'm not sure if that's something you've had patients ask you or others.
I haven't, no.
I've had, I'd say, at least 3 the past week ask me about that. So
Oh,
I've
wow.
just told them, I mean, when it comes to government and things, because you know how they were going to do this whole tracking thing with whoever is diagnosed, uh, which I find is very ableist, honestly.
Yeah.
So I just told them, I mean, we have no control over the government and the tracking. I wouldn't worry about it.
Right.
Like, it's up to them. I tell them whatever you feel comfortable with or not. Like, and I always tell them I could see traits, whether you have it full blown or not. And if you want to continue to get the diagnosis and evaluation, it's up to you. But I think self-diagnosis is valid because they know themselves really well.
Mm-hmm.
And neurotypical people don't ever wonder if they're on the spectrum.
Right.
Only autistic people do.
Yeah.
Like I said, you know yourself and you know something's different.
Yeah.
And then when you get the diagnosis, you have answers to all your questions.
Yeah, it can be. I've had patients say it's very validating for them.
It is, for sure. So some people say it's just a piece of paper, but it's not. It's getting to know yourself better and taking better care of yourself and being the best version you can be.
Right. And I especially say as providers, like I'm sure you've heard me say before, that our role is that we are the guides to the patient. And whatever we can do to help guide them is the most important thing. So whether it's with diagnoses, whether it's with therapy, whether it's whatever, right? Every patient has their own journey that they're on, and we're just like a stop post on their way. We're not a hero, we're not a savior. We are just a guide to help them where they are wanting to go.
Yeah, I think it would help if patients had realistic expectations. I think sometimes they think, oh, I'm going to see a psychiatrist and all my problems are going to go away, you know? The medication is going to fix everything, which it doesn't. I mean, the point is for it to help and to be supplemental to the diet, exercise, the support system, lifestyle changes, therapy.
Yeah, it's a
Like
tool.
with medical.
Yeah. Yeah, I always just say it's a tool. That's all it is. It's just one piece. It's a tool that we have in our toolbox.
Yeah. So it's just being balanced, like with everything else.
Yeah. So, and something else I wanted to ask you actually. So you've been one of the very early members of our coaching program. So thank you for that. So something I was curious about is what drew you towards it. Like, what was it that you were looking for?
A few reasons. So part of it, yeah, you do see the issues with the educational system, how it could improve. It could improve and they could offer more of the scientific background, you know. They could better prepare you for your time management, your interviewing, your ICD-10, your CPT codes, the on-the-job training that you do. Did you get that during residency, like ICD-10? We don't.
We did, yeah. Yeah.
So yeah, there's that, and also healthcare. There's issues with healthcare too. You know, the struggles. It's become very specialized, so we have to communicate with other specialties. You know, there's PCPs, psychologists, therapists, pharmacists. So it's not that we should go against each other or talk bad about each other. We all have the same goal, which is to help patients and to continue improving and learning. And so I feel like a lot of times people are just attacking others, and it shouldn't be like patients against providers or specialties against each other, because that's not the root cause of the issues. The root cause is the healthcare issues and insurances. So if we're so divided against each other, how can we make changes and target the actual root cause?
Yeah, exactly. And that's kind of what I'm realizing too, that there really is a problem in the education system. And quite frankly, I think that they're just like pumping you guys out and just leaving you to dry because it makes them money. So the more graduates that they can pump out, the more money those schools make. And
exactly. And I mean, as an NP, it's not that we're doing anything illegal. We're going to school. We're trying to get educated. We're working on continuing education. We're still providing patient care. We're trying to help out with the shortage and all the same issues. So I don't think we should be the target, honestly, or anybody else, pharmacists or any other specialty. Because, like I say, a lot of times people don't see all the behind the scenes work that we put in, all the studying, all the exams, doing the notes.
yeah, and I don't think our specialty should be enemies either. They're like collaborating pieces as part of a puzzle. That's why they form a collaborating agreement. And yet it seems like the system is out to just put it like NPs versus doctors. Like I've seen that just trend over and over again. And I don't think it's going away anytime soon. And so,
there's differences, yeah, but different doesn't mean worse or better.
Mhm. Yeah, and that's what I tell people is that you're going to be fighting an uphill battle, and especially against bias from other people in the medical system. So what you have to do is just become so clinically excellent that no one can doubt you.
Yep. Good information, good advice.
Yeah, absolutely. So yeah, no, thanks for being here. Was there any like, if anyone's listening to this, right, like future people who want to follow in your footsteps, like what would you tell them?
Not sure.
Anything like you wish you
I
know
think
when
we
you
pretty much discussed all the main points, which is, yeah, there's flaws in the healthcare system, the educational system, but just remind yourself of the reason why you went into the field and your specialty, which was to improve people's lives and to make a difference and to do better. So just focus on yourself and not other people or any negative comments. Same for
that,
patients, not to focus so much on the diagnosis and the label and the stigma, but just know that your own journey is unique and however you feel is valid, and healing's not linear, and that's okay.
yeah.
There's no right or wrong for anybody. You find out what works best for you. And so we each have differences of opinion, and that's okay. We don't have to push our beliefs on others. We can disagree and do it respectfully.
My voice is dying. We're all on our own journey. Yeah. So no, thanks for
Professional and personal and everything else.
yeah, exactly. So I know there's a lot of questions in the comments. I mean, if you want to answer some, we can, or we can just call it here. Up to you.
Yeah, sure, that's fine.
Okay. So I was reading some before, so let me scroll through 'em. Okay. I don't know. Someone said you were really smart. Uh,
Thank you.
Skibidi
Lots
says,
of effort and time. I wouldn't say I'm naturally smart.
of course, that's the key, right? You have to put in the work to level up. That's the difference. Someone said, what shift did you work?
When I worked as an RN in the hospital or currently?
I'm not sure. The question just said, what shift did
So
you
if
work?
it was
Cool.
as an RN in the hospital, it was a 12-hour shift, 3 days a week, 12 hours on, 12 hours off. And then it would alternate some weeks with the 4 days. And then after that, I just switched over to day shift, and it was like Monday through Friday, 8 to 5. And it's still the same, 8 to 5.
Yeah. So standard outpatient hours.
Yes.
Yeah. Inspired to Action said, how do you keep up with notes and charting with that many?
So in my first job, we used Notes, which was a lot of check boxes. So my documentation was not very specific and probably not the best, but I did what I could with what I had. And I wouldn't know my schedule either beforehand. So there was no way for me to like prepare and review. So it's a lot of on the spot decision making. But currently with the software we use Tibra. I know my schedule, so like the whole week in advance. So I open up my notes and I review my documentation beforehand. I don't do the whole week, obviously. I've learned to, now that I have my established patients and I'm pretty familiar with them, it doesn't take as much time for my established. But for the newer ones, yeah, that takes more time because I'm reviewing all the assessments and everything. So usually I do my notes the day before. If I have time during the day, if there's like a no-show, then I'll work on my notes. But usually it's after hours. So at least 2 hours after work, working on notes.
So you really try to prioritize most of it beforehand, but a lot of it you have to do after.
Yeah. So priority is always my new patients and office visits that I will do notes for.
Yeah.
If it's telehealth and it's a coworker's patient that I'm not familiar with, definitely review and do my notes. But if I'm familiar with them, not as much, but I will still look over and have a mental plan in mind.
Yeah, so I forgot to say that in our last Q&A call, but so I ended up getting the AI thing, Heidi, the AI platform. So I tried it with for a week with my private patients, and It works decently well, actually. Basically, you just set it running, and then I'll upload a recording or like what the note looks like when it comes out. But basically, you just create a template, and so I have a soap note template there, and it will just put all of the stuff you guys talk about, and you can tell it how detailed you want it versus how shallow you want it. And then, so pretty much you can just copy paste that soap template, put in an MSC, and I find it works pretty well.
Oh, cool. I'll have to check it out for my weekend side gig.
Yeah,
As far as for my work one, I can't add it at the meantime.
yeah.
Because it's through Tibra, so that would be through like the psychiatrist. You would have to like be up for it, which I don't know if she would.
Gosh, it's worth discussing with her because it doesn't have to integrate into the EMR. You can just open it in a separate panel and have it running. But you just have to make sure that, yeah, she approves it.
Yeah, I should discuss it with her. It would save me time for sure because Tibra is very intensive. Honestly, intake queue is way easier and less time consuming for sure.
Yeah. Okay. Mass Carlo B. Master says, which disorder do you treat the most?
So nowadays, I would probably say the most common would be ADHD, anxiety, depression, insomnia, because my patient population is just different now in my clinic.
Yeah,
Previously, I would say I'd see a lot of bipolar and substance use.
got you. Okay, so it's pretty much just flipped over.
Yeah.
Yeah.
But I still do get cases of like schizophrenia, schizoaffective. For some reason, I don't know, in psychiatry, you can correct me if I'm wrong, but it seems like there's like trends of clusters when I have new patients or just how my day's going. Like I find, okay, today is like my therapy relationship day with everyone struggling with their relationship issues.
Yeah.
Another day it's like ASD, another day is ADHD. It just happens.
Yeah. It's kind of like a magnetism. It just draws all the energy just comes in.
Yes.
Yeah. So Psych NP CEO says, hi, fellow PMHNP.
I
Ivan,
hope so.
Ivan says, okay, so he says, can a person living with schizophrenia get married and live independent or with a wife and kids?
Okay, clinical question. All right. Yeah. So earlier treatment, better prognosis. And it can vary. So if they have early treatment, there's been some patients that have really good results as far as we're able to totally do away with the psychosis. With others, it's a lot more manageable, maybe like whispering once a week, less. So everybody's different. So definitely I'd say it depends on patient compliance and the earlier they seek treatment. Because if you have an adult patient and they refuse treatment, well, there's not much you can do other than sectioning them in this country. And then even when they section them, they can still refuse treatment. So you have to go through the whole court system route. And by that time, it takes a while and they could really deteriorate because with every episode, you get further and further from remission. So it is
Yeah.
possible if they're compliant and they get early treatment, they can live a normal life.
Yeah, I'll tell you a story. So when I was in residency, I had this 19, 20-year-old a patient with schizophrenia. And so he wasn't a patient of mine, rather he was a patient who lived in the area. And he gave us a lecture on schizophrenia from his story. And basically his story was he was around 16, he started getting prodromal symptoms, eventually got worse and worse, tried a couple meds, ran away from home one or two times, and then he got on clozapine. And then clozapine was the game changer for him because when he was on that, he was finally able to be functional again and then reintegrate into society. And in fact, he started going into college. And so because he had that whole 3 or 4 year journey, he lived in the area. So he would lecture to us, the residents, like just like give us talk about experience. And he would go to the med school and talk about that too. So, from last I saw him, he was functioning very well. Like you almost couldn't tell that there was anything that he was struggling with.
Yeah, Cloudsurl is really good. But the only problem is here the frequent lab monitoring, which becomes an issue, especially if the patient doesn't have transportation.
Yeah. It's a shame because it's the medication that people need the most, but the people who need it the most are the least likely to be able to use it.
Well, during the pandemic at my previous job, I had a patient that he would use the Clozaril, but for the insomnia because nothing else had worked, and the Clozaril worked, and it was a low dose. But they no longer had it in Mexico, so he would drive to our clinic, which was maybe, I don't know what part of Mexico he lived, but where I lived before, it was like 30 minutes from the border.
Yeah.
He would drive a few hours. I think he was further in Mexico to
Wow.
see us to get his Clozaril. Because imagine like all the people in that country who had schizophrenia, and let's say they were on Clozaril, and then
Yeah.
it stopped being in production.
Yeah. That's pretty specific.
So I just wonder if that's still the case nowadays, with the Clozaril still in that country, or if it got better, kind of like the ADHD shortage here.
Yeah. I've never heard of a Clozaril shortage though.
It happened in Mexico, happens in other countries.
Yeah. Crazy. So Dominic says, does she perform the ACE before making a diagnosis of ADHD?
So previously in my previous employer, I would do the adult questionnaire. But honestly, with the adult questionnaire, it's just part of it. Rating skills are a guide. It's not the full extent of the diagnosis. Part of it is your experience and the patient and their concerns and how they present. So I could tell, even if they were filling it out, I could tell by how long it was taking them to fill that out. I'm like, I could already tell just by looking at you and what
Yeah.
you're presenting and your clinical symptoms. So I used that then for the kids. It was the Vanderbilt parent-teacher form. Now in my current job, she requires a computer test called CREOS. So CREOS, that's required for all stimulants, whether it's kids or adults, but I really like that one. So it's not covered by insurance, but it's $75, the one-time fee, but they could always retake it to see how they're doing, how they're progressing with their treatment plan and the symptoms. And it also has other cool questionnaires in there. I just need to go in there and explore it. Like it has some for insomnia and sleep hygiene and all these other things. But I personally like it, and I think it's worth the expense because, especially when it comes to kids, they have to have it at two different locations. So the issue with the Vanderbilt is you get the parent form and you get the teacher one, and the teacher one, if you do get it, they say there's no issues whatsoever, and the parent looks totally different. So it doesn't match up. And it's outside perspective. So one of them's the outside perspective from the parent, the other one's the outside perspective from a teacher. So
Right.
you're not really getting the actual feedback from the patient themselves and their struggles. And so with this one, it has it like an interactive type game, and they do it on the tablet there in the clinic. So generally it takes like 15 minutes when they have focusing issues, probably 30, 40 minutes. But afterward, it gives you a report and it breaks it down to their error rate, their response rate, if they're having impulsive issues, is it task management, or what exactly they're targeting. So I always go over it with the parents after, and I tell them if you want to incorporate ADHD coaching, this gives you an idea of what they're struggling with and how you can address it in behavioral ways.
Yeah, I always tell people that clinical rating skills, they're a guide. They can help you, but they ultimately ADHD and all that, it's a clinical diagnosis. So the diagnosis is made on the judgment of the clinician assessing you.
Yep, and overlap in symptoms as well, which you got to roll out other things.
Yeah. Mask Earlobe B Master asks, how do you help people who are intellectually disabled?
So with patients with IDD, it depends on what's going on in their life. Depends what they're presenting with. Are they just needing an eval because they got into some legal issues? Is it sleep issues? Is it anxiety, depression, other coexisting things going on? Usually when it comes to like the actual IDD diagnosis, that's they already have that diagnosis, or they have that done separately by a specialist that diagnoses the criteria, and then they'll say severe or moderate or mild IDD.
Mm-hmm. Yeah, because I know you worked a lot with the population.
Mm-hmm. Yep.
Nicole
Very nice.
Nicole
I
asked,
find a lot of times people have like certain conceptions of them, but they're not really true.
yeah. Nicole asks, constant med change with my bipolar. It's very draining trying to get the right treatment. Yeah, Nicole, maybe you could clarify like the question. So Dominic asked, thoughts on if conduct-like symptoms are only happening in one environment.
Conduct like symptoms, as in for a kid, or
Assume conduct disorder, yeah.
um, so I would say maybe asking more questions and figuring out what's going on. Because it could be that maybe they're masking all day at school, and by the time they get home, they're like fed up and they just let loose. Because usually with the conduct disorder, they're going to have it across the board in other areas, not just in one. So I would ask more questions and find out what else is going on. Or have there been changes like with the parents, relationship issues, or something happen, adjustment disorder?
Mm-hmm. Yeah, I remember that I had this one kid, maybe 10 or 12, and every time he had an issue, it was were yelling, screaming, tantrums, like, oh, this was ODD rather than conduct, but it was always in the presence of the dad. It was like with the mom, sweetheart, with the school, nice kid. It was always just when the dad was home or the dad would, and basically the issue was that they were an immigrant family, and so dad had a lot of expectations on the son. Son would push back, then dad would say you're not meeting expectations and push harder, and then it just became this like
Relationship issue.
exactly it became this relationship issue that started leaking out into other areas.
I think I read this in a book recently. I think it was a trauma book, yeah. And it was saying that the psychiatrist was giving an experience about a patient that they were having a lot of behavioral issues with the mom, and it was a custody battle. And so the lawyers were using it to prove that the mom was unfit to be like the main guardian.
Mm,
And then when he did the intake, he found it was actually the opposite, that the kid felt comfortable and relaxed around the mom to where they were comfortable having those behaviors, and they couldn't do that around the dad because the dad was so controlling and the reaction like they were just on eggshells.
I
I
see.
would say conduct disorder is very obvious. Like there's not a doubt. They have legal issues. So like for kids, they've probably been to juvie, they've probably assaulted people already. So like serious things that you can't miss when it's conduct, as opposed to ODD.
Hmm. Yeah, I remember I had one patient, 16, 17 years old. He had slashed his mom's tires. He had whipped a, he'd gotten arrested for assault against some other kid. He had waved a glass alcohol bottle around with his mom's face. So like there was definite issues that were going on, and like that kind of legal stuff was a lot more prevalent in his picture.
Yep. Juvie, assaulting parents, classic.
Yeah, exactly. But no, I think we just wrapped up the question. So thanks again for hopping on. Appreciate you taking the time.
Yes, thank you for having me.
Of course. Yeah.